Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yasin Taha from the College of Medicine, University of Sulaimani, giving a talk on congenital pulmonary airway malformation. Objectives: to discuss the topic congenital pulmonary airway malformation, abbreviated as CPAM, which was previously known as congenital cystic adenomatoid malformation, CCAM. The pathogenesis, clinical features, histology, radiographic features, diagnosis and treatment of this rare congenital pulmonary malformation will be covered. Congenital pulmonary airway malformation is the most common congenital lung lesion. The incidence ranges from 1 in 10,000 to 35,000 live births. It is also commonly referred to as congenital cystic adenomatoid malformation, CCAM. Presents as multicystic lung mass resulting from a proliferation of the terminal broncholar structures with associated suppression of alveolar growth. Histologically, it consists of cysts lined by cuboidal or columnar epithelium. The Stoker classification of this disease divides or classifies the lesion into 5 subtypes from 0 to 4. The subtypes 1, 2, and 4 are predominantly cystic, while the subtypes 2, 3, and 0 are predominantly solid. The subtypes originate from different parts of the tracheobronchial tree. We start with type 0, which is the rarest form, originates from the trachea or the proximal bronchi, and is characterized by small cysts. And these cysts are lined by the typical respiratory epithelium. Type 1, which is the most common type, originates from the distal bronchi and proximal bronchioles, which consists of one or more large cysts. Type 2 originates from the terminal bronchioles and consists of small cysts. Type 3 originates from near the alveolus, and the cysts are so small so that the lesion looks like a solid mass. And finally, type 4 originates from the alveoli and is characterized by large cysts lined by flat epithelium or the alveolar cells. Type 0 is the rarest form of CPAM, originates from the tracheal or bronchial tissue, as we said, consists of microcysts, cysts whose size is less than 0.5 centimeter, lined with pseudo-stratified epithelium. Mucous cells and cartilage are present, while skeletal muscles are absent. It presents as a diffuse malformation involving the entire lung, resulting in severely impaired gas exchange, and therefore the infants typically die at birth. Type 1 of CPAM is the most common, accounting for 70% of the cases. Originates from the distal bronchi, well differentiated, macrocystic, the cyst diameter is 2 to 10 centimeter, usually consists of single cyst but may be multi-loculated, lined with pseudo-stratified columnar epithelium. The walls contain smooth muscle and elastin. 95% of cases involve only a single lobe. Risk of malignant transformation is rare, transformation into bronchoalveolar carcinoma, and the prognosis is excellent. Type 2 CPAM accounts for 15 to 20% of lesions, consists of multiple cysts whose size is about 0.5 to 2 centimeters in diameter. The cysts resemble dilated terminal bronchioles lined with cuboidal or columnar epithelium. Mucus secreting cells and cartilage are not present. There is little to no mass effect on the adjacent lung. The prognosis is good with no malignant potential. Up to 60% of the lesions have other congenital anomalies such as tracheoesophageal fistula, renal agenesis, intestinal atresia, congenital diaphragmatic hernia, and cardiac anomalies. Type 3 of CPAM accounts for 5 to 10% of the cases, originates in the bronchiolar region. This type typically involves and expands an entire lobe and compresses the other lobes. These lesions are usually solid versus cystic. The prognosis is good with no malignant potential. However, there is typically an absence of pulmonary arteries within the lesion. Type 4 of CPAM accounts for 10 to 15% of the cases, therefore it is considered very rare. Originates in the acinar structures of the lung, resulting in peripheral thin-walled multiloculated cyst with maximum diameter of 7 centimeter, lined with alveolar type 1 or type 2 cells. No mucus or skeletal muscles are present. May present at birth or childhood as tension in pneumothorax or with infection. There is a strong malignant potential and risk of pleuropulmonary blastoma. There are multiple other classification systems for CPAM. Most clinically relevant system simply divides the lesions into either microcystic and macrocystic subtypes. Macrocystic CPAM lesions generally have a favorable prognosis and they are often asymptomatic at birth, while the microcystic lesions generally they have unfavorable prognosis, more likely to be solid appearing on imaging and more frequently associated with other anomalies. So in this CT scan we can see a peripheral large air cyst which might be a type 4 CPAM. PA and lateral views of chest radiograph showing left lower lobe CPAM, chest CT coronal view showing left lower lobe pulmonary CPAM in the picture on the left side, chest CT sagittal view showing left lower lobe CPAM on the right side of the picture. The clinical features of CPAM: we might have prenatal presentation, which ranges from incidental findings on ultrasound to fetal hydrops. Fetal hydrops refers to generalized edema of the baby, which might be fatal. The peak size occurs at 25th weeks of gestation, but many CPAM lesions may regress. If large enough, CPAM lesions can compress the IVC and the heart, resulting in increased central venous pressure and leading to heart failure. Fetal hydrops and demise or death may occur in severe cases. The neonatal presentation of CPAM: the majority of CPAMs present at birth are of type or subtype 1. The presentation is in the form of tachypnea, retractions, grunting, and cyanosis. Type 4 may present as pneumothorax, and there is a strong suspicion of malignancy. Type 3 can also present with severe symptoms at birth, often associated with pulmonary hypoplasia, and it can involve the entire lung, resulting in severe progressive respiratory distress and respiratory failure. It is more common in males. The treatment of CPAM is surgical resection for all symptomatic lesions with respiratory distress. Surgical resection is also offered and recommended to older children with less acute symptoms. The idea of doing surgery is to prevent recurrent infection and to eliminate the risk of degeneration into malignancy. Thoracoscopic lobectomy is the most frequent treatment or the treatment of choice. Prenatal diagnosis and treatment of CPAM: widespread use of prenatal ultrasound has increased the identification rate of this or the most common bronchopulmonary malformations. Sometimes the diagnosis is confused with congenital diaphragmatic hernia based on ultrasound. MRI is occasionally used in fetal diagnosis. Cystic lung lesions remains the most commonly identified pulmonary anomaly. Ultrasound may have difficulty in differentiating between CPAM and bronchopulmonary sequestration. However, if apparent vascular supply is present, this favors diagnosis of bronchopulmonary sequestration. MRI can be used if both lesions are confused together. If there are no in utero complications, actually distinction between the two lesions may be irrelevant. The overall prognosis is related mostly to the size of CPAM. Small cystic masses, often incidental findings, they present as incidental findings, asymptomatic in utero and postnatally, while very large masses impose important physiological sequelae. Esophageal compression from these very large masses can cause polyhydramnios. Mass effect on the unaffected lung causes pulmonary hypoplasia. IVC and cardiac compression causes low cardiac output or low output congestive heart failure and fetal hydrops. Fetal hydrops may present as ascites, pericardial and pleural effusions, edema of the skin and the scalp, heart failure. Historically, fetal hydrops is viewed as a harbinger of fetal or neonatal death. Fetal hydrops led to the development of fetal intervention for such lesions. There are various methods of fetal intervention in CPAM: corticosteroid treatment, fetal endoscopic intervention, such as thoracoamniotic shunt, open fetal surgery, such as open resection of cystic masses, and the exit procedures or the extrauterine treatment. Corticosteroids, there are case reports of fetal hydrops which have resolved, and fetuses or fetal survival after administration of steroids, but the reason is not clear. Other cases of some shrinkage of cystic lesions with steroid administrations have been observed. Still, steroid use is highly controversial and experimental. Fetal thoracocentesis and thoracoamniotic shunting is a minimally invasive procedure, effective in large space-occupying effusions in bronchopulmonary sequestration or dominant macrocystic cysts. In one study, 9 fetuses with hydrops were successfully treated with shunting and survived. All require definitive resection after delivery, tolerated well by the gravid uterus, but still requires tocolytic agents, which are the labor suppressant agents. In this picture, we see the fetoscope as well as the balloon used in fetoscopic procedures. Open fetal surgery is extensively studied in non-human primates. It is a surgical technique requiring anesthetics and tocolytic regimes. Effort to select fetuses with life-threatening lesions, only performed at few select centers. Extensive prenatal evaluation is needed to exclude other associated anomalies. So this is a picture demonstrating the open fetal surgery. Another operative photograph of open fetal surgery. This is also another operative photograph of open fetal surgery in CPAM. So open fetal surgery, if meets all other criteria, massive multicystic or solid CPAM with hydrops can be resected prior to the 32nd week of gestation. The largest reported series consists of 22 cases, of whom 11 survived. All lesions were resected from the 21st to 31st weeks of gestation. 16 with required single lobectomy, 4 double lobectomy or bilobectomy, and 2 required pneumonectomies. All survivors had resolution of hydrops within 1 to 2 weeks. Open fetal surgery. Deaths often due to preterm labor and resultant demise. For fetuses reaching the 32nd week of gestation, prefer early elective delivery with ex utero resection. Exit procedure with resection prior to division of the umbilical cord or placement onto ECMO support at the time of delivery. The prognosis is still poor even with extracorporeal membrane oxygenation support, the so-called ECMO. Ex utero intrapartum treatment, also called as an exit procedure, is a surgical procedure that is used to deliver babies who have airway compression due to cervical teratomas, cystic hygromas, or a blockage of the airway, such as congenital high airway obstruction syndrome. Predicting who will progress to hydrops is very important. So there is a measurement called CVR. CVR is the CPAM volume ratio, which is calculated by dividing the CPAM volume over the head circumference. So if the CVR is more than 1.6, this is suggestive of progression to hydrops, while most CPAMs don't progress in size relative to fetal size after the 28th week of gestation. Twice weekly ultrasound examination is required for fetuses whose CVR ratio is more than 1.6, while weekly ultrasound examination is recommended for those whose CVR is less than 1.6. Once show signs of developing hydrops, considerations of fetal interventions should be taken. Postnatal resection. Typically, presence of CPAM or bronchopulmonary sequestration is an indication for resection regardless of symptoms. In asymptomatic newborns, often wait until 3 to 6 months of life. Pleuropulmonoblastoma and bronchoalveolar carcinoma both were reported in patients with known CPAM. May need preoperative imaging for sequestration, and depending on the location or size, most commonly the lesions require lobectomy. Increasing use of thoracoscopic resection in postnatal treatment. It is characterized by shorter hospitalization, reduced pain, improved cosmosis, and less overall morbidity than thoracotomy. However, there are limiting factors to thoracoscopic resection, such as instability and in lesions so large that they limit the working space. There are special considerations in postnatal resection. Lesions so large requiring pneumonectomy may result in temporary hypertension or respiratory insufficiency from pulmonary hypoplasia, may need to make plans for ECMO support temporarily. Well, these are some selected videos which can simplify understanding the subject of CPAM. We have to remember that CPAM is a rare form of congenital pulmonary lesions, and the pediatric thoracic surgeon may see only a few cases in a lifetime, and therefore the treatment is best performed, or the management is best provided by referring centers. And we have a
congenital pulmonary airway malformation, abbreviated CPAM, is a lung malformation that usually affects a single lobe of one of the lungs and forms during fetal development. The old name for CPAMs was congenital cystic adenomatoid malformation, because they have both cysts and glands in them, but are terribly malformed and disorganized. CPAM cysts are continuous with the airways, so they're filled with fluid in utero and become filled with air after birth. The cause of CPAMs isn't known. It isn't even known whether they're a developmental failure or if they're a type of hamartoma, which is a benign overgrowth of tissue. Sometimes the growing CPAM can prevent normal healthy lung tissue from developing, causing pulmonary hypoplasia, which is underdevelopment of the lungs. Also, a CPAM can push on the heart or large veins, causing blood to back up throughout the fetus's veins. When that happens, fluid can start to leak into the fetal tissues, a condition called fetal hydrops. Whether or not any of this happens largely depends on the size and location of the CPAM. CPAMs can arise from different spots along the tracheobronchial tree, and that's how they're subtyped. The 5 subtypes are named 0 through 4, with type 0 coming from the most proximal airways, the trachea and the proximal bronchioles, and type 4 developing all the way down in the alveolus. Type 0 CPAMs develop at the trachea or proximal bronchus with small cysts, but are pretty rare. Type 1 CPAMs, which develop in the distal bronchi and proximal bronchioles, are the most common and have one or more large cysts, with tissue-like cartilage in between the cysts. Type 2s come from the terminal bronchioles and have smaller cysts. Type 3s arise almost all the way down to the alveolus, and have cysts that are so small they look like a solid mass. And type 4s develop in the alveoli and have large cysts. In addition to the size of the cyst, the 5 types also differ in the kind of epithelial cells that line the inside of the cysts. Type 1s are lined with ciliated, pseudostratified columnar epithelium, the same epithelium that makes up normal bronchi, whereas type 4s are lined with flat alveolar cells, which is just like the alveoli that they come from. Symptoms of babies born with CPAMs vary. Some are asymptomatic, whereas others with pulmonary hypoplasia can have serious breathing difficulties. CPAMs can also get repeatedly infected, and can also lead to a pneumothorax if the CPAM develops a hole someplace that allows air to go from the airway right into the pleural cavity. Finally, CPAMs are associated with lung cancer, specifically bronchoalveolar carcinoma and pleural pulmonary blastoma. Most CPAMs are diagnosed on prenatal ultrasound, and if one is seen, then there's typically a follow-up fetal echocardiogram, which is a dedicated ultrasound of the heart, as well as a fetal MRI to look for any associated malformations. As an example, type 2 CPAMs are often accompanied by kidney and heart defects. CPAMs can grow, stay the same size, or even regress during pregnancy, so they need to be followed over time. If fetal hydrops develops, it might be necessary to pull fluid out of the CPAM to make it smaller, or to place a shunt from the cyst to the amniotic cavity to help it drain, or to do surgery to remove the entire CPAM. Alright, as a quick recap, congenital pulmonary airway malformations are cystic lesions that occupy some or all of a lobe of a lung. They can cause a number of problems like pulmonary hypoplasia, pneumothorax, and recurrent infections, so they're usually surgically removed.
Hey guys, thanks so much for watching. So this is a pretty short video, but hopefully you learned something new about congenital pulmonary airway malformation. This video is brought to you by Philip, who wrote the script, Rishi, who edited, Tanner, who did the voiceover, and I did the illustrating and editing. As always, if you love our videos, be sure to share us with your friends on social media. And if you want to learn more about this topic or the topics of our other videos, definitely check us out at osmosis.org. We have some really awesome studying materials on there, such as flashcards, quizzes, studying schedules. And if you don't believe me, check out our Facebook page. We now have over 1,000 reviews on there. So definitely take a look at those. All right, guys. Thanks again. See ya.
So our first job is to make sure the diagnosis is correct. Once we're sure it is a CCAM, we try to put it into one of three categories. It is one that is likely to shrink, and we need to just monitor and be sure that that occurs. It is one that is a large CCAM. It's not threatening to the baby before birth, but is likely to need immediate care after birth, so we need to make sure that the right place of delivery occurred and the right team was there to deal with it surgically after birth? Or is it the very rare one that may need intervention before birth and actually removing the CCAM before the baby's born and allowing the pregnancy to continue? So that would be the fetal surgery group. So one of the good things about a CCAM diagnosis is that the majority are self-regulating, meaning they can expand and look very scary, but then will shrink spontaneously, and there's no need for any intervention at all in utero or in the newborn period. There is a subgroup where that abnormal proliferation continues, and while the rest of the lung is developing normally, the mass effect, that is the chest has a finite volume which it can accommodate, and if the CCAM gets too big, then it starts to squash the other organs that are in the chest. It starts to put pressure and compression on the other developing lung that can start to hurt the normal development of the lung. And it can also put pressure on the heart itself and the big blood vessels that are returning blood to the heart, such that the baby will start to develop some swelling. What we call hydrops is the name we call that swelling or edema. That's generalized swelling of the baby that we can detect by ultrasound. So it's only in that rare subgroup, and we don't know precisely, if we had 100 babies diagnosed with CCAM, how many are going to go on to develop problems versus how many are going to regress. We suspect that the vast majority, perhaps as many as 90%, will go on to regress, and we won't actually have to do anything except monitor and be sure that regression is occurring. But it's the 10% or less that regression does not occur. Continued expansion of the CCAM occurs, and we start to see secondary problems, either from too much compression of the lung or compression of the heart, and that swelling and hydrops develop. And that's the group that we believe we need to monitor very, very carefully, perhaps with as often as every 3 or 4 days, repeating the ultrasound to see how rapidly the progression is occurring. And it's that small subgroup that we may need to consider an intervention before birth in order to prevent progressive cardiac compression and eventually fetal death. But it's a very rare subgroup, and the majority of babies with CCAM will do well.
Frequently, many of them are asymptomatic at birth, and that's wonderful. And the option for treatment in that situation is to let the infant grow. We generally will do a chest x-ray or 2 after birth to assess how the lungs look and the size of the CCAM. But frequently, we'll let the infants go home and see them in an outpatient setting. In that situation, we'll bring the infants back at 2 or 3 months of age and get another imaging study called a CAT scan. After that point, the general recommendation is that CCAMs be removed. The reasons for removing a CCAM include infection of the lung or infection of the CCAM itself. The other is that there's a very small potential for malignancy or cancer within the CCAM, and that would be the other indication to have the CCAM removed. The exact timing of the surgery, though, is very controversial, but generally we would recommend by a year of age that the children have their CCAMs removed.
A prenatally diagnosed lung tumor can be described as a large lump of non-functioning lung tissue that's growing within the fetal chest. No one knows the cause, there are no known risk factors, and it's not inherited. Therefore, I view these lesions as simply a random error in how a piece of the baby's lung has formed while in utero. There are 4 basic categories of lung lesions that can be diagnosed by high-frequency ultrasound. The categories of all of these include benign lesions. The first and by far the most common is the Congenital Pulmonary Airway Malformation, or CPAM. CPAMs can be described as a lump of non-functioning lung tissue that has a tendency to form either large cysts known as macrocysts or small cysts known as microcysts. To make the terminology even more confusing, CPAMs have been formally referred to as CCAMs, or congenital cystic adenomatoid malformations. However, recently pathologists and pediatric surgeons have favored the term CPAM simply because of the way that they look like under a microscope. However, for all intents and purposes, families should be aware that CCAMs as well as CPAMs are essentially describing the same entity. The second major category of lung lesions is quite rare, and it's known as a pulmonary sequestration, also referred to as a bronchopulmonary sequestration, or BPS. I view these lesions as an extra piece of lung tissue that has formed, is non-functional, and however is supplied by a blood vessel that's coming from the aorta, which is the largest blood vessel in the body. The third major category of lung tumors is actually a mixture or a blend of the first 2 categories, so therefore it's called a hybrid lesion. Hybrid lesions consist of cystic lung tissue that is supplied by a systemic artery coming off of the aorta. And we now know that up to 25% of fetal lung lesions are indeed hybrid lesions. The fourth category of lung lesions is known as a congenital lobar emphysema, or CLE. These lesions are very rare and are composed of cystic lung that is very floppy and stretched out, such that at birth these lesions collect and trap a lot of air and grow larger and larger in size, kind of like a balloon. And as a result of their large size, they can then compress normal lung and cause compression of the heart, which is obviously important in terms of pumping blood throughout the baby's body. Regardless of the type of lung lesion, what really matters is the actual overall size of the lung lesion in comparison to the fetal chest. When lesions get very large in size, they can compress adjacent normal lung, or they can compress the heart and great blood vessels, putting the baby at risk for complications, and in the worst case scenario, even death. All of these lesions are very rare, and most physicians, including obstetricians out in the community, see only a handful, if that, during their entire careers. Understandably, then, because of their rarity, there's a lot of misinformation with regards to these lung lesions and their prognosis. Fortunately, at the University of Michigan, we counsel a lot of pregnant mothers who have fetal lung lesions and understand the issues. Based on a complete and thorough investigation and evaluation, we can determine the risks of these lung lesions and give you the complete understanding about how to deal with them. In experienced hands, the prognosis in the vast majority of fetal lung lesions is actually quite good, and most children lead a normal life.
Baby girl Blake first came to us as a fetus about halfway through her development, which was actually before 20 weeks, at 19 weeks, which is very early. And when she first came to see us, while she was still inside her mom's tummy, we found that there was a gigantic left-sided lung malformation.
They sent us on to a specialist, and they noticed that her heart was pushed over all the way to her right side of her rib cage. And so they were like, well, that's kind of odd. We thought so too. That doctor sort of knew what it was, but not really. And even though he had told us that he was the specialist in Dallas for this type of thing, he would have to look it up and, you know, go home and maybe your baby won't die. After we went home, we cried, got upset, and then we got mad and got on the internet and managed to find what she has, which is a CCAM, and then found Texas Children's from there.
When the Blake family first came to see us, they had a very careful, comprehensive evaluation here at the Texas Children's Fetal Center, which included a careful study of Harley's heart. To be honest, when the Blake family first presented, I thought for sure that we were going to need to perform fetal surgery to actually go inside and remove this lung mass. And fortunately, over that 2 or 3 week period, it did not get worse. It didn't get better yet, but it didn't get worse.
Our child's health is our responsibility, and you know, she's a fetus at the time. So it's like, you know, you work with doctors, you work together, and it's like you have to also be responsible for your child's health and know what's out there, because you can't just rely on one. You have to say, you know, I'm going to do 2 referrals, 3 referrals, and keep going until you find the answer you want. Because we don't know what would have happened had we not had the foresight to say, you know what, we've got to fight this.
The Blake family really wanted to deliver here, particularly at the new Texas Children's Pavilion for Women, just to have the team around that could respond if Harley were to have any problems or any symptoms.
If she's just a happy, healthy, normal baby, you wouldn't even know anything's wrong.
Harley recently had surgery, but we've removed that malformed tissue. She's recovered beautifully from that, and I believe that she has every opportunity to be a completely normal baby.
Yeah, we found Dr. Cass and Dr. Olatoya, and just with everything that we read about them and read about Texas Children's and have heard by reputation, you know, we decided, you know, that was the place for us.
Over the last decade or so, Texas Children's Hospital has been able to build an expert team that has expertise in everything to do with fetal medicine. I think just having that team all in one location allows us to get the best outcomes possible for babies, even with the sickest and most complex conditions.